Have you started your period unexpectedly at work, your gym, or your alma mater and not had a period product? Maybe they were blocked by a coin-operated period product dispenser. Well, it doesn't have to be that way. I'm Claire, the founder and CEO of Flow, and we stock over 60,000 bathrooms with our freely accessible period product dispensers. Learn how to get our products at your organization at antflow.com.
Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all.
Hello, listeners, and welcome back to the Heart of Healthcare podcast. I'm your host, Steve Krause, and I'm really excited about today's episode. It's a very current topic. The suggestion for today's episode came from a loyal listener, a guy named Joe Hinderstein, who slacked me on the Health Tech Nerds Network and said, any chance you could dedicate an upcoming Heart of Healthcare episode to unpacking the big, beautiful bill? And so we're going to try to do that today. And when Joe Hinderstein asked me that question, I immediately thought that the group that we need to go to do this and have on the podcast is the Marwood Group. And today we have Joseph Mercer, who is Managing Director at Marwood, joining us. And so Joe, by way of background, is one of the most well-known healthcare policy subject matter experts when it comes to what's happening in DC. And that's what Marwood does, is they work with a lot of private equity, venture capital firms, public equity firms, and companies to really understand how the regulatory winds are changing in DC. And Joe's one of the leaders of that firm. He has a long history of working at CMS before joining Marwood. And we're just super excited to have him on the podcast today. Joe, thanks for joining us.
Thank you so much for having me. I'm excited to be here. It's, as you might imagine, I've talked about what became this bill pretty much every single day for the last 7 months. So it's something that I'm excited to talk about today.
Well, great. Well, we got the person to help us here. So I want to start by unpacking the name of this piece of legislation. It's been referred to as the big, beautiful bill. We obviously know it's a bill. It's now a legislation. But let's start with the word big. And big connotes something that is significant, right? And I'd ask you to frame for our listeners, Joe, where does this stand over the last 5 decades in terms of the impact that this bill will have on our industry of healthcare?
It's up there, right? It's definitely the biggest thing. I would say the biggest single healthcare bill in terms of changing overall coverage, in terms of changing funding structures since the Affordable Care Act. So you go Affordable Care Act, you go Balanced Budget Act in 1997, and then obviously you get some more foundational bills back in the 60s. I'm sure that some of my older colleagues will tell me I'm forgetting something big from the 1980s. But I think, Balanced Budget Act in 1997 had a massive change in Medicare. ACA expanded coverage by, 30 million people or so. So obviously that's a huge deal, even if the numbers here are not anywhere near what CBO thinks. And even if the cuts aren't quite what CBO thinks, the change in overall covered lives is pretty significant. The only other one, because I think this is probably something we need to mention later on, the American Rescue Plan had a reasonably decent size increase as well, just because those enhanced exchange subsidies have helped grow that market by 12 million people or so. This doesn't exactly touch that, but it sort of speaks to the broader impact. So that's another one that we would highlight. But in terms of losing maybe 4 or 5 million people from coverage, either on an ongoing basis or on a every year churn basis from Medicaid, along with some other changes and along with really making states have to think about their funding structures and some funding structures for hospitals, it's right up there.
It sure seems that way. And then the second word is beautiful. And beautiful connotates that someone really likes this. And I want to talk about the impact. It's clear there are a number of losers in this bill because, in truth, there's a lot of cuts to our industry. But who are the winners? Who will think this is beautiful?
I would say the number one group who thinks it's beautiful is the existing Senate and House Republicans who fought the repeal and replace war and lost and could come back around and do some of the Medicaid changes that they wanted to do. It's very much targeted at the Medicaid expansion population. So I think that's on the front end, probably that's who's going to be happy. I would say hospital lobbyists in the short term are upset, but in the longer term, they're happy.
Why is that?
Well, because, great question. The reason I say that is because as much as the Senate didn't make major changes, and we can dive into the policy a little more later, didn't make changes to the provider tax and state-directed payment cuts that were, that have vexed hospitals the last couple months, and was a little bit of a surprise that the Senate went bigger than the House on that. What the Senate did do is push the implementation date to 2028 from 2027.
Right.
What that means is if Democrats take the House in the midterm, what you can have is you have a situation where potentially you have an opportunity in 2027 to lobby to push back and try to continue to delay those bills. So it's something for hospital lobbyists and others to try to, to dive into. And so I said it with all the love in my heart, but there's certainly there's some job security.
Your view is the final chapter of this book is not written, given the way that this legislation was structured in terms of the rollout.
That's right.
Time. Yeah.
That's right.
So you actually raised something that I talked about, big bills, and obviously the ACA, which you referenced, was one of the largest over time. And it did strike me, is this effectively a repeal of the ACA or a pullback of the ACA at its core? I mean, 10 million people supposedly are going to lose Medicaid, maybe more, but the CBO's brought that down recently. 5 million people probably lose ACA coverage because of the enhanced subsidies or some changes there. Like, is that effectively what this is in your mind?
It's as close as you're going to get, right? It's I don't think you can go much further than that. I think that one thing that is a positive for the industry, or like a positive for the total number of covered lives, is that there is a greater level of popularity, and there's things in this bill that were built on some of the frameworks or some of the considerations around initial repeal and replace. But yes, it's about as close as you can get, because between, let's say, 2026, where the enhanced subsidies will expire unless something major changes in the next couple of months, you'll lose between 4 and 7 million people between 26 and 27, probably lose another 4 to 5 million people. You're still well short of the coverage gains from the Affordable Care Act, but is still a major pullback, and it's something where it's limiting Medicaid expansion in a way that, as much as you can't get rid of it, I don't think it does limit it. I mean, this bill makes it very, very difficult for any state that hasn't expanded Medicaid to do so, because there are significant financial penalties attached to it in terms of how your provider taxes are treated. And so it's about as close as you can get to repeal.
Let's go deep now, and let's go through some of the major provisions of the bill. And let's focus on healthcare. Clearly, there were lots of other things in this big, beautiful bill, but that we're focused on healthcare today. I mean, you could go deep, and I've read a bunch of your papers that go super deep. For folks who want to dig deeper, I encourage you to reach out to Marwood. But why don't you talk to me about the 3 or 4 most important provisions as you see them and changes in this bill? How would you rank them?
Sure. So the number one, I think, both by dollar amount and by impact in terms of covered lives, is the Medicaid work requirements. So a long-standing interest. We saw the Trump administration approve some 1115 waivers back in 2018. Judge Sean Bates of the D.C. District Court rejected all of those, though we did get a little bit of an example of what that looks like in Arkansas. We'll talk about that more in a minute.
And the 1115 waivers were allowed states to actually try work requirements.
Exactly. Yep. And so they were able to do that. And then what ended up happening is stakeholders sued and said you didn't have the authority to approve them. So they got pulled back. Well, we did get 6 months of evidence of what this looks like in Arkansas. We'll talk about that in a second. So basically what the work requirements do is they say, if you're a Medicaid expansion enrollee, meaning you're a working age adult between 19 and 65, you have to do 20 hours a week of community engagement is what they'll call it. That could be working, that could be volunteering, that could be a jobs program, that could be education, or a combination of all of those. States have to look at this, give people at least a month, but they have to do this review at least every 6 months. Mm-hmm. And so what this is designed to do is ensure that people are working or fall within another exemption. So if you have a disabling mental or physical illness, if you are in substance abuse treatment, if you have a disabled child under 13, if you've just been in an inpatient hospital stay, those are all reasons you could be exempted.
But for instance, a single working mom is not exempted from this.
That's correct, unless they were on Medicaid through a different pathway, like that, unless they were on Medicaid because they're a caretaker or something like that. But yes, a single working mom, let's say you have a 12-year-old and a 10-year-old, you have to be working. That's correct. So the reason I bring this up as such a big deal, and the reason that CBO scored it as costing 4 to 5 million lives, and that's, by the way, that's between 20 and 25% of the Medicaid expansion population nationwide. It's a pretty big number. Right. Is based on what we saw in Arkansas. In Arkansas in 2018, the state estimated that about 3 to 4% of the individuals who are subject to the work requirements were not either working or falling under another exemption. Despite that 3 to 4%, 25% of those subject to the work requirements lost coverage in the first 6 months. Now, Arkansas did things that you're not allowed to do anymore. They only allowed web-based submission of results, and the web page was only open from 9 a.m. to 5 p.m. for some reason. Well, I know what the reason is, but some reason. And so now, based on that experience, the law says, look, states, to the extent possible, have to use ex parte information. They have to look at payroll taxes. They have to look at encounter data. So they do need to take steps to try and reduce this disruption in coverage. But I think it's really important to note this is a very significant administrative burden in a already administratively burdensome program.
And is there any precedent also when you looked at Medicaid redetermination, some of the challenges of that can be a corollary to what's going to happen here from an administrative perspective in your mind?
Absolutely. There's two things. One is more macro and one's a little bit more micro, but I think it's worth thinking about in the ecosystem. On the macro, it's hard to remind people. It's hard, people, when you have a change, if you haven't done something in a while and all of a sudden you're asked to do that, you may have a change in address. You may not be looking at your email if you've opted into email. There's all sorts of reasons why you may not know, hey, this is coming down the pike. And so just as an example on that, Michigan spent $28 million, I believe is the number, on outreach in 2018 when they were about to impose their own work requirements under Rick Snyder. They got blocked right before it was supposed to go live. But even though they spent tens of millions of dollars to try and tell people about them, they were set to lose 33% of their Medicaid expansion population on the first day. Wow. So it's just hard. I think that's a problem. So we saw that during redeterminations. And this goes actually to the more micro point, is that what you're likely to see here is an increase in churn. You saw like Centene, for example, they complained quite a bit during redeterminations that people who lose coverage but don't actually have a change in eligibility are very problematic for Medicaid managed care. Because you lose somebody for 3 months, they come back on, you've lost 3 months of per member per month premiums, but you didn't lose the cost when they come back and go to the hospital.
Right.
And so I think that's something to think about as far as like states are going to have to consider that. Any downstream vendors working with Medicaid managed care are going to have to think about the Medicaid managed care plans, which are pressured now. And then obviously, as you think about various different providers, it's a big deal for hospitals, but we've seen a lot of activity in behavioral health and medication-assisted treatment, things like that. You're just going to have a little more churn where you either have a little bit of bad debt uncompensated care, or you're seeing patients who are just going to be a little bit sicker and a little bit worse shape because you might have missed some time here and there and it takes time to get back on.
I want to ask you, in addition to going through some of these lessons, which I know we just talked, the key tenets of the bill, we only just talked about one. I also want to sort of any lessons you might have for our entrepreneurs and our executives and company leaders and others that work here. But let me ask you one question, because on the behavioral health and substance abuse population, I thought you said that the work requirements exempt them. So if you have a substance use disorder, you don't actually have to prove that you have to meet this criteria. But it sounds like you're concerned about the impact even in that population. Can you go a little deeper there so I understand that nuance?
Yeah, I'm concerned because it's an exemption, but I don't exactly know how to automate that exemption, right? You can use encounter data and say like this person is currently using medication-assisted treatment services. They're getting methadone, they're getting buprenorphine. And if that's the case and you can automate it to a certain extent, that's great. And maybe that's easier. One issue I have is like, what happens if you don't have that automation? You want to ask for an exemption, but that means that the state needs to build a process that gives trust, because otherwise you're saying, I'm going to tell the state as an individual that I have a substance abuse disorder, that I'm a drug user, or I have problems with alcohol. Like, I think that's very challenging. And so you think about the administrative burden, you think about the population that's using these services and whether or not they're willing to come to the table.
Any opportunities you think here for entrepreneurs or company builders that might be able to help with this work requirement restriction, if you will?
Absolutely. Anything on the front end that can help providers across the spectrum, skilled nursing facility, hospitals, behavioral health, physician offices that serve more Medicaid patients, that can help them identify very quickly somebody's actual status and coverage and work through the exemption process and try to use, either intake or other information or any sort of data scraping to make sure that you can identify very quickly that somebody, needs to go ahead and apply for coverage and follow up with them. Going beyond that, patient engagement, you probably have to expand out a little bit more to do a little bit of outreach. You've seen companies in the past, I think there's a company named Centauri, helping generate opportunities to get eligible, I think makes a huge difference. But also, I think there's an opportunity. You have these established vendors on the state side that are bigger, the Gainwells of the world, the Conduents of the world, that are working with the states. But I think that there could be some opportunity to help them and build out some opportunities just to work with the states directly as they try to figure out how to work this and how to build these systems.
It strikes me that there's going to be a massive infrastructure need for these states. Like, are the states ready for this? I mean, I know some states tried it in Arkansas, you referenced Michigan. It sounds like there wasn't a lot of success. Like, this strikes me as almost a parallel a little bit to the ACA. I mean, not as massive, but the ACA rollout of centralized exchanges, state-based exchanges, it kind of all was a cluster, if you will, at that time. It's gotten better since. But are we going to face that in terms of just headlines of administrative angst and anger versus of our government?
Yeah, I mean, the answer is it depends on the state. And I'll explain why. So I was at CMS doing ACA implementation in 2013. So that just gave me a little bit of a shiver.
Sorry.
My stuff worked. It's okay. So the way I would think about it is, if a state does not, I don't want to say does not care, but is less interested in doing everything it can to keep beneficiaries enrolled, the risk to the state being ready is lower, because you're just going to say, here's the system, just whatever off the shelf thing you can find. Good luck, figure it out. Beneficiaries will figure it out, right? The number of beneficiaries will go down and it'll come back up as they figure it out and providers figure it out. In a state that decides, let's say Pennsylvania decides they're like, we don't want to lose anyone, right? I mentioned Pennsylvania, there's a lot of CCIIO alums there. Like, they're going to say, we want to cover as many people as possible. They don't have a lot of time to do that. There is a waiver program available. If a state has made a good faith effort to be ready for 2027 and they're not, they can push it back if they give a timeline. I'm not sure how generous CMS under President Trump will be in allowing those waivers, but there's an opportunity. But yes, I think that even for states that are interested in making sure that as many people remain enrolled as possible, those systems are going to be challenging and there's going to be a lot of bumpiness. The good thing is that you mentioned redeterminations earlier. States did get a little bit of a feel for where their systems are in that massive stress event. And so I think they have a better idea, but funding doesn't get easier. Everyone's looking at states are more pressured in funding than they were during redeterminations with some of the COVID money drying up. And so I think that becomes a factor. In repeal and replace, when they were going to make all these changes, they actually increased the administrative match for states for 3 years. That didn't get into the bill here. So states are going to be dealing with, there's some money. I think it's $100 million nationwide for work requirements, but that goes only so far. So I do think it's going to be an issue. I think what it's going to look like is versus Secretary Sebelius on The Daily Show getting lightly made fun of by Jon Stewart because her website doesn't work. It's going to be, what happens is you do hit that 5 million people losing coverage in the first year, and then it bounces back over time towards more of like a 2 to 3 million people down and a bit more churn in the system.
Interesting. So you think there's going to be like a deeper J curve, but a bounce back up? Okay.
I do, yeah.
Because you said people will learn how to either meet the requirements or at least already did meet the requirements, but understand how to deal with the administrative burden. Okay, let's go. Exactly. Let's go to the second biggest tenet of this bill as you see it impacting our industry. Sure.
So the next one I'll talk about, I'm going to do them together, provider taxes and state-directed payments.
Yep.
So just as a bit of background, because I think it can be a confusing conversation, I'll just describe both of them very briefly. The way that provider taxes work, it's a funding structure for Medicaid for states to come up with their share of the Medicaid spend. So what they do is they say, hospitals, you owe us 6% of your revenue. Hospitals covering Medicaid commercial lives. Medicare's carved out. 6% of your revenue for those lives in the year. Rather than putting that to the general fund or spending it somewhere else, the state just turns around and spends it on Medicaid. And so then that triggers a federal match. So let's say you collected $100 million from the hospitals. You now get a $150 million match from the federal government, depending on your FMAP and some other issues. You get a big match from the federal government. So now all of a sudden you went from $0 of state dollars to $250 million that you spend on the Medicaid program. It makes sense why Paragon Institute was able to sell this as Medicaid money laundering, but it is something that the structure is built into the statute. So states have been doing it for 40 plus years, but it is something that was driving some concern. The other piece of this, and we'll talk about the actual provisions. State-directed payments, just very briefly, they're created in 2016 as a way for states to pass along supplemental dollars to Medicaid providers, even in Medicaid managed care. There's no structure in the law for that in Medicaid managed care. So states use a mishmash of different funding structures. And CMS was like, no. I can't deal with like 10 or 15 of these across all these states. This is the process, get it approved every year. But over time, CMS has approved higher and higher reimbursement levels for the hospitals in particular, going up to 100% of an average commercial rate, meaning that rather than getting paid at Medicare like they would in fee-for-service as a maximum level of Medicaid, they get paid at 2+ times Medicare. So these are both concerns that I think have been raised this year by a number of commentators. And what the bill does is, in essence, is freezes for provider taxes. What it does is it says no new provider taxes. If you're a non-expansion state, that's all. Just no new provider taxes. If you have them, you can keep them, and that's it. For expansion states, though, it says no new provider taxes, and starting in 2028, we're going to phase down the maximum amount of revenue you're allowed to take from these providers to fund this. Right now, it's 6%. It goes to 5.5% and then phases down 0.5 percentage point a year until it gets to 3.5% in 2032. So that's a considerable decline.
And for non-expansion states, it says no new provider taxes. But if you were charging 6% before, is that what you get to keep?
You get to keep, yeah.
So basically, expansion states get kind of hosed. Is this right? Because their provider tax goes down?
Yep. You'll notice there's a theme here, right?
Yeah.
Work requirements, Medicaid expansion beneficiaries. This expansion states have an actual decline in their funding. Very, very specific goals in this legislation. As I mentioned, and as you highlighted, it's a little bit of like a repeal and replace redux to the extent possible.
Got it. Okay.
So one caveat, skilled nursing facilities are carved out of that. Their provider taxes are actually left in place. So for investors, I think the way to think about it is like if you're thinking about a growing company, especially a provider of any sort or somebody selling into providers in a Medicaid expansion state, you have to look and say like, what are the provider tax? What is the provider tax regime in the state? Maybe they're under 3.5% now, so there's no risk. But if they're at 6%,
they're getting basically
haircut,
40% haircut on their Medicaid and commercial.
Yeah, not full Medicaid. But like this one structure is good. That is a big because obviously hospitals are a huge part of the healthcare ecosystem. So it's a not insignificant potential cut.
And Joe, a lot of the talk out there, and I want to talk about the politics of this because this is the one that gets me. I'm just so intrigued to see how this plays out. But let's stay on the substance for a second. A lot of talk out there. Are these the two provisions that are really going to hurt rural health hospitals? Because that's been the talk is like, and maybe it hurts, Mass General too, in my neck of the woods, the academic medical centers. But I'm curious, like when we talk about the rural health hospitals being really hurt and potentially a lot of them going away, like are these the two provisions that hurt them?
Yeah, these are the two biggest ones. A lot of the rest of the money, it would be too boring for everyone for me to go through dollar by dollar. But this between the work requirements, provider tax, and state-directed payments, it's about $650 billion in pay for of the just under $1 trillion.
Right.
A lot of the other changes are either like funny budget math or smaller ball issues. And so, yes, this is what's going to hurt hospitals the most.
And why rural hospitals hurt the most by this? Is it because they just have a larger concentration of Medicaid patients?
Yeah. And they're closer to the edge, right? If you're facing, they're going to be the ones, because a higher Medicaid population means you're going to lose more people from work requirements, but then you're also going to be like a net gainer when it comes to provider taxes because you're serving more Medicaid patients, so you're going to get more dollars in.
Yep. And at the last minute, there was this Rural Health Transformation Fund, I think, which I understand only covers about a third of that loss. Like maybe you could talk about the politics of that and what that's meant to do. And is there opportunity there for potentially companies or entrepreneurs?
What the rural hospital slush fund, I guess we'll call it, is $50 billion. It starts 2026, $10 billion a year. And, and that money continues to run just until 2031. A lot of, there's an application process, you have to be using it to serve certain communities. So there is an ongoing opportunity to help identify who should look for those dollars
Yep.
and who should try. Because I know, from a public investor perspective, one thing I heard is a lot of people being like, actually, like the life points and communities of the world are going to be really well situated to draw down a lot of these dollars. And so therefore, that's partially why you haven't seen those stocks take as big a hit. I think that it's like the way we got here, to answer that question a little bit, is that like Senate leadership was not super interested in moving away from these Medicaid financing measures. I think that they were worried about the reconciliation process and worried about the parliamentary process and losing pay for. So like the SNAP pay for example, diminished, and they had to find money to fill that in. They were worried about going back to the House. They were worried about some of the hardliners, even in the Senate Republican caucus. And so they wanted to do this. They were afraid of backing off. And this is one way to try to satisfy, to a certain extent, some members, because it's a big chunk of money, even if especially if there's a disbelief in CBO, this is a big chunk of money that is like, you can hold in your hands a little bit more versus like, well, maybe we have some coverage losses. The other thing to think about, if you take a look at some of the members that were most opposed, like Josh Hawley was very opposed.
Yep.
He's somebody who the provider tax issues, as much as he cares about it, it's a good tool to use in the future. Missouri's actually not that bad off because of provider taxes. So like getting a year plus rural hospital funds is probably a win for Missouri.
Is that because Missouri wasn't an expansion state?
They are an expansion state, but their provider taxes are lower level. They only have a 3.5% provider tax for their hospitals now. So there's not a risk there.
Yeah. So it's like a net positive for him.
Right. And he turned around and introduced a bill to delay these cuts anyway. So like he was very brave a week late, but delay things a little bit and push this back. So that's the politics of it, is that like it's attractive to both Republicans and Democrats, these slush funds of just saying like, here's a bunch of dollars you can look at and point to and say, this is how much we're getting for our state, versus trying to explain away. I've had to do this all year, trying to explain away state directed payments. Right. Very, very challenging. Saying here's $10 billion this year is easy.
How much do you worry there's going to be an issue in the rural health communities? Like, they're already healthcare deserts, if you will. Like, how much should we be concerned about that as a system based on this bill?
I worry about places where there's a double hit of work requirements and ACA exchange. So one state I'll just call out. We don't ever spend a lot of time here, and it doesn't seem like a lot of public companies really spend a lot of time here. But one state that's worth mentioning is Louisiana. Because Louisiana has a really, really large Medicaid expansion program. I think they've added like 750,000 people or something like that. And then they've also, what you see oftentimes is really, really big Medicaid expansion programs typically have seen less growth on the ACA exchanges just because the populations don't overlap entirely, right? Whereas like Florida and Texas see massive ACA exchange growth, but partially that's because they don't have expansion.
Right.
Louisiana has seen massive growth in both. So if you think about like a rural hospital there, if these subsidies expire, you get a hit in 2026. You're going to see some people getting uninsured, some people moving to bronze plans, meaning that their coverage is less usable because their deductible is $9,000 or whatever, and you're making $16,000 a year. And that, I'm not a math guy, but that doesn't feel right in terms of like you'd be able to use your coverage. And so I think you hit in 26. Then 27, you have work requirements come into play. So now you're going to lose another big chunk. And so rural hospitals in that environment, I do think there are some on the edge that will close. And I don't think it's going to be a complete catastrophe. I think states are going to try and do whatever they can. And I think that's where you could find yourself making the argument for delaying provider tax and state-directed payment cuts, because you're going to start to see it in 26. And start to see it a little more in 27 and say like, okay, we can't do this yet, right? We need to give states more tools versus less to try and fill this in. And so I do think that if everything went into place without any change, you would see, I think they've talked about 300 rural hospitals at risk of closing. I'm not sure you'd get to 300. I think states would figure things out, communities would figure things out, but like that's not an insignificant number that are at some risk either of closing or making changes, moving towards just an emergency room.
So I get, and you said, and people probably thought you were flipping at the beginning, but you actually weren't. You were serious. Like, this is why healthcare lobbyists are going to do well over the next bunch of years, simply because the national laws, we're only a couple chapters into the story, as I referenced, and then you have all these state like ways to navigate this, right? So there's just I think there's a lot to be seen, is what I hear from you, even though the headlines are really bad right now, and it probably is still going to be a massive impact. How it actually shapes out is going to be, in your mind, is unclear.
Yeah, there's a lot of state decisions to be made from here on out, and the state decisions are going to make a huge difference, right? How they want to do their work requirements, how they want to work around it, and there's how states want to try to figure out how to address less funding than they would have had otherwise here. So yeah, there's a lot to come.
Let's move to the politics of this a little bit, because you obviously you guys focus on the policy, but the two are intertwined, and you see the politics unfold in real time. Because as you said, you spent the last 7 months talking about this. So if I were to think about the evolution of this, and I'm probably going to simplify it, but let me try to do it at a high level. Well, as you said, there's long been a desire from Republicans and House Republicans and Senate Republicans to kind of peel back, right? Rip and replace, or now slowly peel back the ACA. But then Trump said, we're not touching Medicaid, right? That's sort of, I remember the kind of first stake in the ground, if you will. And then you start to see the language be like, well, we're going to focus on fraud, waste, and abuse, right? And then it's sort of, you had the Republican House Republican version, which was, I think, counterintuitive to most people, is actually softer than ultimately the Senate version. Like, how did that all play out? Because it's clearly not just fraud, waste, and abuse dollars. I'd love to get your perspective on how much is fraud, waste, and abuse, but it's sort of evolved. And honestly, like the Congress this is the one case where they kind of guided Trump, I think, to what they wanted from where he began, at least in this phase of the second Trump administration. But maybe I didn't get that right. And how did the politics play out in your mind?
I think the way we got here, Trump talked about that a lot. I think the fraud, waste, and abuse message helped a little bit, because I think when considering the initial potential big scary things like reducing the federal matching rate for Medicaid expansion from 90% to whatever the state's federal matching rate is for traditional Medicaid, that was a terrifying policy, right? Per capita caps, terrifying policy. So you started with those as these are the initial forays, and it's well, we're not going to do that. And then compared to those work requirements, which at the time CBO had scored it as about $100 billion saver, which I thought was a little bit low, but whatever, they're making the numbers. That was something well, that's not so bad, right? And provider taxes hadn't really come into play. They were in the discussion, but not really. The idea, even Brian Blaze from Paragon at a healthcare conference this winter was I think we can maybe get 6% to 5%, but that's the best we can do. We're not going to get any better. That's how little attention they had received on that. So it was a lot of work requirements, some Medicaid rules that haven't gone into place. You can get yourself to $500 billion pretty easily, and people got comfortable with that. And then, you continue to have a lot of this well, I don't know, the provider tax thing. It's this is the state just coming up with money, and it just sort of stuck in people's craw. And the House at the last second obviously was okay, well, we need more money. Let's do a little bit here. Let's just freeze them at current levels, which is not, which is worse than certainly I expected them to do. I think a lot of the members of the House that were concerned about Medicaid were basically saying, what, the Senate's going to save us. And so everyone just let it happen, right? That no one was willing to vote against it at that point, because let the Senate do it. Well, they'll make it easier. We have Josh Hawley pounding the table every day and saying we don't want to deal with this. It gets to the Senate, and it becomes clear that one random conversation from March that Politico and others reported on, that where John Thune and Mike Crapo said, whatever they're talking about are not enough. We need to cut Medicaid a lot more. I didn't take it as much, because his own caucus was saying we don't want to do anything. And turns out they were very serious about going bigger. They needed to find savings, and so they went bigger. And then, basically the initial draft, and this is go a little bit more of the politics of it, because otherwise I'm just describing it. What we heard from people is the way that Leader Thune and Chairman Crapo looked at the initial draft of the Senate bill was, we are going to make this as harsh as possible. We are going to make people come to us and explain why they need their policy. We're going to find out exactly who cares about all these policies. And that's healthcare, and that's other stuff, right? That's for the docs, they didn't get their 2.5% bump that the House had. They had to fight back to get that. They clearly cared enough there. But what they learned was that a lot of these members were willing to take something smaller, and they were willing to use this in part to get other things they wanted. Lisa Murkowski got lots of nice things for Alaska.
Right.
Josh Hawley got the radiation exposure fund increase. That was very important for him. Some other people got things in their states and for other things they cared about. And ultimately, they relied on the fact that everyone wanted to get the bill done.
It's like classic negotiation strategy. Go in with what you want, it could maybe even go a little deeper, right? And then trade away some things.
Right. I think one place where I know that I misestimated this year, and I think a lot of people fell into the same trap, was I said a lot of times, hey, there's not going to be big Medicaid cuts because it's not a healthcare bill. So who cares about it? But it turns out that's actually the wrong way to think about it. That's the opposite. Because the fact it wasn't a healthcare bill meant there were so many avenues. There are so many places to go to say, well, here's something here, here's something there. Hey, we have to get this tax bill done for the big guy. We have to get this done for ourselves. Let's do this now. And so that became enough of a push. If this was only a healthcare bill with these Medicaid cuts, I would argue it would have been challenging to the point of possibly impossible.
That's really interesting. But let me ask you something. And I want to come back to the timing, and maybe you can intertwine it to your answer. But the Republicans have for a decade and a half tried to run on repealing, replacing, tweaking healthcare, and they've lost every single time, right? They've just lost. And, if I think about a lot of the base that flipped to, Trump MAGA 1.0 or Trump 1.0, and then in 2.0 clearly is much more rural, white Americans, folks who might have been former Democratically aligned or at least independent are now have flipped. This strikes me as flies in the face of what their base probably wants long-term, is to lose coverage. Does this ultimately become known as a healthcare bill? I mean, obviously the rich win on the tax cuts, right? Poor, underserved folks, I think, lose on healthcare. What does this become known as in your mind? I mean, I know you're not a prognosticator, but how do you think about that? Because you made this great point that it's not a healthcare bill on its face, but does it become known as one?
I think ultimately that will be the negative for Republicans in selling this is that the tax changes were in large part continuations of a previous tax regime.
Yep.
So it is a tax bill in terms of in avoiding pain you would feel otherwise, but it's always hard to say if all the computers in the world crashed on January 1st, 2000, Y2K would be considered a bigger thing, right? But it was fixed first, and therefore you got there, right? Rather than seeing a major tax increase, you avoided it. You do get punished for that a little bit. And so I do think that, especially given that Democrats are going to make a huge deal out of this, the healthcare provisions will be talked about more than anything else in the next few years. And does that present risks to Republicans? I think the answer is yes. I think they're hoping that because the impact starts in 2027 and beyond, that it's not a problem for the midterms. But it is something that could be a little bit of a drag as you move forward. It could also be a drag, to your point, in some of these populations that shifted towards Trump and towards Republicans in 2024. Maybe you lose them even if you don't have those cuts. I don't know what will happen from an electoral perspective. I've been surprised many times in the last 10 years in terms of electoral politics, but I do think that Democrats in particular make sure that that's the leading conversation coming out of this. I don't think calling it the one big ugly bill is going to be the winning message, but right, as they were trying to do yesterday, but talking about the coverage losses and the potential impact will be a centerpiece.
Just curious, other areas where innovation has been happening. We talked about the ACA. Are there any direct impacts on the ACA in this bill, or is that more about the enhanced subsidies ultimately expiring, which could happen if there's, my understanding is it could happen in September, right? If there's not a continuing resolution, or
if the subsidies do not get extended, the change happens January 1st, 2026.
Yep.
September is an opportunity to extend them.
Yeah,
but it's not but that's if you wanted to do that then. But this bill, it does something really, I think, really interesting. It's really important for non-expansion states, Florida and Texas in particular. Historically, if you misestimated your income, which makes sense if you're working a shift job and your kid gets sick for 2 weeks, you might make less money than you expected and move into or out of your income bracket. You misestimate your income historically, you were limited in how much you had to repay in your subsidies. So if you were making 100% of the federal poverty line, you had to pay a couple $100s instead of thousands of dollars in subsidies. What this bill does is it says it doesn't matter what your income is, you have to pay back the full amount. That's really important in Texas and Florida because I think there is a little bit of fudging going on for the people who would be in Medicaid expansion but aren't eligible because they haven't expanded, saying, I'm at 95% of the federal poverty line. I have no subsidized coverage. I'm going to estimate it at 100%, knowing it's $600 LOI.
Yeah.
So I think that makes a difference. There's also some provision. So I think that's going to be a drag on coverage in those states, even if you extend the subsidies. And then they also have some initial verifications, basically saying that states are required to check other trusted sources if the person doesn't have a tax bill to point to for their income verification. And so things like that are going to make it a little harder to get into ACA coverage, increase the administrative burden for initial coverage on the ACA exchanges. That's the bigger one. The big scary thing, the funding, the cost sharing reduction subsidies, which would shift the relative costs of the silver plans and the bronze plans and the gold plans to the point that they would be quite damaging to the marketplace. That got pulled out. But the rest of those provisions, it's not catastrophic, but it will dial down the coverage, particularly in non-expansion states.
Yeah, and you see folks on the ACA exchange pulling back guidance for next year as well. Anything on ICRAs in this bill? I know that was a Trump 1.0 movement, and it persisted in Biden. Anything there that we should be thinking about?
So the House, I believe the House included ICRA, permanent extension ICRA. I do not believe the Senate included it. The House also included a tax credit for employers to add ICRA plans. If I'm wrong, we'll have to talk about that later on. But I believe the Senate dropped it out. Now, what I would say on ICRA is, even with the House language, I was a little bit concerned that the upside for ICRAs is limited without the enhanced subsidies, even if the users are not the same. The problem is that if you're an employer and you're trying to consider what you're doing, it limits. If you've never offered coverage before and you're going to say, here's $3,000 a year to go spend it somewhere, and we just want that certainty, that's easy, right? It's either nothing or this.
Yep.
But if you're offering even like a kind of bad fully insured plan, and now you're saying, hey, you've seen all these headlines about premiums going up 30% or 35% the last 2 years. Good luck.
Totally.
That's obviously a much harder conversation.
I get it. Your point is the ACA and the impacts on the ACA and premiums going up, which is what's going to happen. And insurers already announced that, right? That's good. That would impact the number of people who would actually choose going the ICRA route versus the employer-sponsored insurance route. And then finally, well, maybe two last questions. HSAs. I know first dollar coverage by employers was put into this bill. Anything there that
for telehealth,
for telehealth? Anything else that we should be thinking about, or entrepreneurs should be thinking about around the HSA high deductible front?
Yeah, I think the two other things for HSAs that are really interesting here. One is allowing people to have HSAs when they have a worksite clinic. There's lots and lots, right? I mean, I walk around to investor buildings in New York, and there's clinics on site. And it's possible there's a carve out there, and I'm sure there's some workaround in the tax code to deal with it. But that's a not inconsiderable part of the population, especially in more rural areas, that if you have a clinic on site at your job site, you can't get an HSA. So I think that's an opportunity for expansion in terms of the total lives. And then direct primary care. I think there's a lot of concierge medicine groups that have worked around that by saying you're going to pay us $1,000 for a wellness visit that your plan doesn't offer, and then that covers you for the year. But this puts them on more solid footing where people feel more comfortable. So those two areas, I think, are ways to expand out what people can do. The first dollar for telehealth, we've seen that it barely just expired. So I think that is positive. A great expansion for telehealth. I think it's a modest expansion in the population for HSAs, because otherwise I think it was a little bit of a limitation in the last couple of years, because you get to a saturation point for there's only so many people for whom a high deductible health plan plus HSA, it's great for me. It's not great for everyone out there. And so I think that this allows that population to expand at least a little bit to make it a little more interesting.
Final additional area I want to touch upon. I mean, obviously, Trump 2.0 is linked with the MAHA movement, right? Make America Healthy Again. I'll make a comment. In some ways, pulling back Medicaid leads to less preventative care, which flies in the face of the MAHA movement. That's Steve Krause's personal editorial. So I don't know how we get our head around that. But put that aside. In this bill, are there any other areas where they've advanced the MAHA movement that folks should be aware of?
Nothing in so many words. I think it's possible in some of the nutrition, nutrition areas, there's something that's positive in there. On the healthcare side, I wouldn't say they've necessarily gone in that direction. I think where that'll be interesting more is that as you as you see the White House weigh in on any sort of Medicare Advantage or like waiver movements in, one thing that's in this bill that has an impact a little bit is budget neutrality for 1115 waivers in Medicaid. You've seen the administration make some announcements on 1115 waivers in the last few months, basically saying we're going to tighten up what we've approved in the past to like strict statutory definitions. And so one area we've seen a lot of expansion in Medicaid is and in Medicare Advantage is using like food as medicine as an example, as a way to drive patient engagement. And say we're going to put this on your counter, and but in order for it to keep coming, you need to go to these preventive care visits. I think we're watching very closely to see if there's any pullback on some of those waivers. I think we think that based on their language, that's not going to happen, but that would be a place where you could lose some of those gains in a hurry if you don't allow that to happen.
Yeah, totally. And final question, we've had Andy Slavitt on this podcast, and I think it was he who said, frankly, a major piece of healthcare legislation comes around every 10 years or so, right? And so he was pointing to the ACA as the last one. And I guess even though this isn't a healthcare bill, maybe this is the next one. Either in the near term, medium term, or long term, where are the areas that you guys are watching for major pieces of healthcare legislation regulation? What should be on the lookout?
Yeah, I mean, I think Medicare Advantage is one. I mentioned it earlier. There was a House hearing yesterday where you saw they're getting different sources. Democrats are all citing MedPAC. Republicans are all citing the Wall Street Journal, and that's a bit of a change from where we were in the past. And so I think that that's an area where I think that if you're a hospital, if you're a telehealth advocate, there's just a lot of money there. So I think there's interest in reforming that program. I don't think that's a fast turnaround event. I think that's a couple years out, but that's an area where I think there's a lot of interest.
Do you think that happens in the Trump administration, or do you think that's the next administration?
I think you could conceivably see it in Congress during this administration. That might be getting a little over my skis. There's a lot of conversation now. A lot of people, a lot of hospital folks and other folks are excited about the prospect of it. The drumbeat's never been louder, but even then, you go back 10 years, you only see a few selected pieces of Medicare Advantage legislation. So I think there's a long growing period to get to that point where industry is going to be fighting tooth and nail. But I think that's the next big place. And then the question is that sort of related to this is what do you want to do with the Medicaid population you're losing here? What do you want to do with the ACA population that's changing? Are you going to try and address that again? Is it going to just be repatching the same way? Or is this just going to be sort of ignored for a little while? And because of the way electoral politics look, you're not going to see a full Democratic lineup potentially for some time.
Joe, this is a tour de force of healthcare policy, at least under this piece of legislation and the impact. I know our listeners are going to love this episode, so I just really appreciate you coming on and sharing your expertise and your perspective. So thanks for all that you've done here and also all that Marwood does for our industry.
Well, thank you very much for having me. It was a great time.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.
In the time it takes you to actually board a flight from Group 8...
Now boarding Premier Altitude Elite Club members.
You could have bought a Hyundai on Amazon. Visit HyundaiUSA.com or call 562-314-4603 for more details. Limited availability, pickup through participating Hyundai dealer in select markets.